Hello everybody, my name is Ashley Gates and I'm going to be doing my presentation on peptic ulcer disease. So you may be wondering, what is peptic ulcer disease? Well, a peptic ulcer can be referred to as gastric, duodenal, or esophageal based on its location. A peptic ulcer is an excavation that forms in the mucosal wall. Erosion of the area in the mucous membrane is usually the cause, and it can even extend into the muscle or the peritoneum surrounding the tract. The pathophysiology of peptic ulcer disease. Peptic ulcer disease occurs when a gastroduodenal mucosa cannot withstand the digestive action of gastric acid and pepsin. The damaged tissue cannot secrete enough mucus to act as a barrier to HCl and pepsin. When there is damage to the gastroduodenal mucosa, it allows for a decreased resistance to bacteria, and that bacteria can infiltrate the mucosal layer and cause an infection. H. pylori infection can easily enter due to this decreased resistance and is a major cause of peptic ulcer disease. There are a couple different contributing factors to the development of peptic ulcer disease. The body has natural defense mechanisms to prevent a peptic ulcer from forming. These defenses include mucus, bicarbonate, blood flow, and prostaglandins. Mucus will coat the inner lining of the digestive system to prevent the acidic digestive contents from eroding the mucus layer. Bicarbonate secretion by the surface epithelium in the stomach and duodenum maintain a nearly neutral pH. Endogenous prostaglandins stimulate alkaline secretion in both the stomach and the duodenum and can also increase the thickness of the mucus layer adherent to the mucosa. Aggravators like H. pylori, NSAIDs, acid, pepsin, and smoking can all contribute to increased stomach acidity and corrosiveness. The use of NSAIDs can inhibit the secretion of mucus that protects the mucosal layer. There are two different types of ulcers associated with peptic ulcer disease. The first type of ulcers are gastric ulcers. They are characterized by dull, aching pain after eating, bloating, indigestion, and heartburn, painless bleeding, and secretion of normal to less amounts of acid. Duodenal ulcers are associated with heartburn, bloating, and severe stomach pain. The pain is going to be worse than when the stomach is empty, and it is caused by an oversecretion of acid, and they're typically more common. The assessment of a patient with peptic ulcer disease is going to be characterized into three different sections. The first portion is going to be the patient-reported symptoms. They will typically report a dull burning pain in the mid-epigastrium, pain that is relief after eating, pyrosis, which is also heartburn, vomiting. This can occur sometimes but not all of the time in patients, and constipation or diarrhea. And that diarrhea can be contained of melena, which is just in usually about 15% of patients. The physical examination is we're gonna find most likely that the patient's in pain. They're gonna have epigastric tenderness or abdominal distension. Some of the diagnostic tests used in the diagnosis of peptic ulcer disease is endoscopy, which is the preferred method, and sometimes they'll do occult stool testing as well. There are 3 nursing diagnoses that I would associate with peptic ulcer disease. The first is acute pain related to gastrointestinal irritation, risk for ineffective gastrointestinal perfusion related to the ulcer, and nausea related to gastrointestinal irritation. I compromise the treatment for peptic ulcer disease into 2 sections, the medical treatment and the nursing treatment. The combination of PPIs, antibiotics, and bismuth salts are the most common treatment for PUD because together they suppress and eradicate H. pylori. PPIs and H2 receptor antagonists are typically used together to treat NSAID-induced ulcers, or ulcers that are not associated with H. pylori. The main goals of the first drug regimen of PPIs, antibiotics, and bismuth salts is to fight an infection, where the goal of the second drug regimen is to promote ulcer healing. A pyloroplasty or antrectomy is only recommended to patients who have not responded to at least 12 to 16 weeks of medical treatment, life-threatening hemorrhage, perforation, or they've had an obstruction. The nurse should help the patient identify situations that are stressful or exhausting. The patient should be taught to eat during restful times and not during stressful situations. Studies have shown that smoking decreases the amount of bicarbonate that is secreted from the pancreas to the duodenum. Some dietary modifications that could be made are avoiding extreme temperatures of food, that being too hot or too cold, meat extracts, alcohol, coffee, caffeinated beverages, and diets that are rich in milk or cream. When evaluating the effectiveness of the treatment for peptic ulcer disease, we're going to make sure that our patient is experiencing decreased pain after the treatment. We're going to want to ensure that they are adhering to their medication regimen so that they can get feeling better sooner. And we need to watch for the complications of peptic ulcer disease, like hemorrhage, perforation, penetration, and pyloric obstruction. Some of the symptoms of these complications are going to be sudden severe upper abdominal pain that persists and increases in intensity, referred pain into the right shoulder, vomiting, fainting, a board-like abdomen, hypotension, tachycardia, and eventually this could lead to shock. How will my future practice be influenced by now what I know about peptic ulcer disease? I will watch for the signs and symptoms in patients who are at risk of developing PUD. I will assess my patient's stress level and recommend relaxation techniques. I will teach them the proper use of NSAIDs. I will encourage them to quit smoking and to limit their alcohol use. I will teach patients proper dietary intake and what foods could exacerbate PUD, and always view my patient holistically.